If you're trying to conceive and feeling overwhelmed with fertility advice, then this podcast is for you. Welcome to Don't Tell Me to Relax, your fertility podcast and antidote to unhelpful fertility information. I'm Hannah, a fertility acupuncturist, teacher and campaigner for better fertility education. This podcast aims to empower and inform you about your menstrual cycle and fertility. It's basically all that information you didn't get in sex ed at school, with the aim of improving your understanding of your reproductive health and optimizing your fertility. Hello everyone, and welcome to this episode. In this series, we are really taking a look at assisted conception and a lot to do with IVF. And so for this episode, I'm joined by Ed Coates, who is the medical director at the Evewell. And the Evewell is a private fertility clinic here in London. It's a clinic where we share lots of people who are having acupuncture with us and treatment with the Evewell. So it has a really good reputation. So before we talk about assisted conception, Ed, would you like to introduce yourself, introduce the clinic and say a little bit about your background?
Yeah, no, thanks, Hannah, and thanks for inviting me to join you for this. It's a pleasure, and it's nice to talk to people from all different specialties. I think over my sort of 10 years or so, longer than that now, working in specifically IVF and fertility, much longer in obstetrics and gynaecology, I think I've realised it's not all about sort of just the doctor at the end of the chair. We need all sorts of different sort of inputs, and whether that's from acupuncture, nutritionists, urologists in the field of fertility, I think that's important. I mean, over my 10 years specifically, I've worked in lots of different clinics. I think some clinics do it really well. I'm proud to be part of the Evewell. We do a very, it's an incredible service in terms of how patients are looked after from the moment they sit down to hopefully leaving with success. And if we don't have success, you can be pretty sure we'll do our very best to give you answers as to why it hasn't been happening, which is as important as well. But yeah, I'm all yours to ask as many questions as you want of us. The Evewell is in West London, as you say, in Hammersmith. I'm sitting in my office today. I'm in between patients. But yeah, if I can help anybody out there who's listening, who wants to find out more about their fertility and IVF, and I'm yours today to ask any questions. I'll do my best to answer all of those questions.
Fabulous. We won't keep you long because you are a busy man. But where I would like to start is actually right at the beginning. So could you explain a little bit about assisted conception? Because I think often we just think IVF, but assisted conception is actually a much broader topic. So could you explain what that is, first of all?
So assisted conception really refers to any type of help that you need with conception beyond not conceiving naturally. Now, there are many, many reasons other than heterosexual couples not getting pregnant that people therefore need help with. Let's talk about male factor for a second. Men who have erectile dysfunction or have problems with achieving penetrative intercourse or ejaculation is one clear example where actually you may not need a fully blown IVF cycle. You may actually start with something more simple, which is something called intrauterine insemination treatment. And that's just one area. Before we get on to all the more advanced things like IVF, you've also got patients that sadly don't reliably ovulate. And there's a very common gynaecological condition called polycystic ovaries. And for some patients, that can mean that they don't reliably release an egg each month. And that makes it incredibly hard if, as a woman, you would expect to have 12 periods a year and 12 successful ovulations. And within that, around 80% of heterosexual couples would expect to conceive. If you're only having 2 or 3 periods a year, you can see how that would lead to fertility difficulties. And that's one condition. Of course, there are many, many more sort of less well-known things. Endometriosis is a common condition that we deal with in the clinic. Patients often have scarring and inflammation in their pelvis, and that can make pregnancy harder too. And those patients may well need a treatment called IVF. But actually, the whole spectrum of helping patients to conceive is what we do here, and we cover all of that as well as gynecology. But we do an awful lot of IVF, and IVF is a big cornerstone of helping people who perhaps have been struggling to conceive, perhaps just for a short time with known problems. So if you know that you've got blocked tubes and you've only been trying 2 months, you don't have to wait 2 years, although most roads will lead towards IVF after a couple of years. In most scenarios, it's not absolute. And we mustn't forget as well the LGBT plus community as well. And we use assisted conception such as donor insemination and as well IVF to help same-sex female couples and same-sex male couples with surrogacy to be able to start a family.
And so if you are in a heterosexual couple and you're trying to conceive and it's not happening, like at what point, because people ask us this all the time when they come to our clinic, it's like, what point do you move from continuing to try to having investigations done? I know like the NHS guidelines are like 6 months to a year. Where do you stand on that?
Well, the NICE guidance is now almost 10 years old, and I think we recognise now people perhaps do leave families later, and I think age is really important. So if you are 41, I wouldn't suggest for 1 minute that you should wait a year to get investigations. We're seeing people more and more now, I think, as the conversation's changing with podcasts like yours and the way social media is now, who are actually being much more proactive rather than historically, I think, going back just 20, 30 years where people were more reactive to problems. So rather than waiting for problems to occur and then having tests, which is sort of where the NHS guidance is sort of directed, really waiting for a period of time. But that's based around good evidence. That's based around the fact that we know most people will conceive within those first 6 to 9 months. Then you should just begin to have tests. But I think you've got to look at the individual situation. And I think if you know that you don't have regular cycles, or you've always had painful periods, which might be a sign of endometriosis, or perhaps you had sexually transmitted infections when you were younger, these are all things that can cause infertility. Don't wait, be proactive, get some advice, and a simple appointment and a few tests, it can often make the difference between perhaps having success, and if you leave it too late, perhaps not having success. So it is important to be proactive, I'd say.
Yeah. And you know what? That is the sort of thing that we talk a lot about when, like, I do like courses around sort of educating people around understanding their menstrual cycle, understanding their fertility, because so many people say, I wish I'd known sooner and I wish I'd done something sooner. It's like the two most common sentences that we hear. And I think that comes from a lack of awareness or understanding, because, so many people are put on contraception or, don't have cycles, and so might not actually know that there is a problem with their cycle that could be a bit of a flag for their future family. So it's about sort of getting information, isn't it? As much information as soon as possible so you can go and make informed decisions.
You're right. And I couldn't agree more, Hannah, actually, because I think when I think back to my school days, it was all about sex education and not having a pregnancy. And I think there's a huge piece of work that we need to do. And I think it's already started. I know the Royal College has done a piece of work on this. The British Fertility Society are keen, but it needs to be from a very early level educational. So people are not sadly coming and sitting in a clinic at the age of 38 and being told that they don't have a good egg reserve, or worse still, that they can't conceive with their own eggs, which is huge. The impact that has on an individual, a couple, their relationship, but also the knock-on sort of mental health issues that can sometimes stem from it. So I think we have to be really much better earlier on at educating people so that we think about it earlier. And that's why the clinic here in the Evewell in the West of London, we see everything, whether it's gynaecological. And I always, when I see my gynaecological patients, talk a bit about fertility as well, because I think it's important. Sometimes that's sort of on the radar, but they don't want to bother you with the questions because they've come for something else. But it's important to educate as well. So that's, I think, one of our roles. So it's great to hear that you're also doing that from your clinic side of things as well. Yeah,
because it just breaks my heart when people sit in clinic and say, if only I'd have known this in my 20s. And you just think, because you're in a completely different space, aren't you? If you're in your late 20s and in your late 30s and you've got endometriosis or polycystic ovaries, and you hadn't really known the extent of that because you'd been on contraceptions for years and years and years. And it's just not good enough.
Yeah, and I think as well, I know endometriosis, and I think GPs get a bit of a raw deal actually, because obviously the first thing when someone has painful periods is not to whisk them off and do surgery, is to start with the contraceptive pill. And I think as a good gynecologist, and that's what you would start with. But as you say, if you then the education around the possible diagnosis and what that might mean is the piece that's missing, I think. And I think we are getting there, but we just need to be better at it, because it can have devastating impacts on people. There's nothing more heartbreaking, as you say, than seeing someone in their sort of late 20s, newly married, finding out that their ovaries are depleted of eggs. And then it's just, it's really, really hard, especially if they said, gosh, I knew 8 years ago I probably had endometriosis. So there are lots of conditions out there. Endometriosis is not, on its own. There are many conditions which I think are important. So it's about being proactive with your health. And, I think we're possibly the British system of healthcare is to be more reactive and to sort of keep going. And I think we maybe don't help ourselves because the healthcare is quite hard to access. So yeah, I think it's my view is education and being proactive so that you don't have those difficult conversations later on when you really want something to happen.
So when you go in for treatment, so say you're kind of on that path for treatment, how do you decide what kind of treatment to go for? So again, let's say we're talking, a heterosexual couple who are not conceiving. Why would you look at IUI or IVF? Why, what's the kind of benefits and differences?
So I think a lot of things factor into that, and there isn't sort of an easy answer to that question. But if we think really sort of, and this is not meant to sound patronizing, but very simply, to make a baby, you need eggs, you need sperm, you need a womb that works well and doesn't have any structural issues. And we can get into what all of those problems might be. And you need fallopian tubes, of which you normally have 2 of those, working well. Now, when you put all of that together and you think about the sort of what's needed, you then have to think about is the age of the patient and other health conditions that may factor into that. So when a patient comes into the clinic, we start with some very basic tests, such as checking your ovarian reserve, checking with a scan. If I say to patients, and they probably think I'm nuts, but if you were to maroon me on a desert island and say, which one fertility test could you take with your machine? I mean, you'd never be able to plug it in, but it would be the most sensitive tool because you can look at the ovaries, you can identify polycystic ovaries, you can count the follicles, you can see fibroids, you can identify polyps, you can see endometriosis in some cases. So if you were to say what one test is your sort of best test, an ultrasound. So it's the cornerstone of what we do. So an ultrasound and a simple blood test can tell a woman quite quickly if there are any major issues. And we mustn't forget male factor. I think quite often, if I had £1 for every person that sits down, and it's assumed that the woman must be the issue, and it often isn't. It's 40% of heterosexual couples' problems are male factor. And you can dig right in. That's a huge area. I mean, you can dig into all of these things. But I think some basic tests really are helpful to guide in answering your question, which is what treatment can you go down? So if a man has, for example, not normal sperm parameters, you need to think about why that might be. And that is certainly linking into diet, lifestyle, nutrition. I mean, the good thing about men is that usually you're producing sperm a bit more like a factory. So you're producing it all the time. So therefore, if you put the wrong fuels into your body, you can have a bad amount of sperm or quality of sperm coming off the production line. But actually, if you're then very good for a period of time, and it takes around 3 months, 90 days to make a sperm, you can change those things. So that's the good news. But, if a man had poor quality sperm and they've been trying for 2 years, you wouldn't ideally go down the route of insemination treatments because they don't have high success rates, around 8 to 10%. Whereas in couples that are doing IVF, you're looking more like sort of 35 to 40% live birth with unscreened embryos, and actually more like a sort of 55 to 60% live birth rate in some age groups with genetically screened embryos that we know are healthy. So there isn't an easy answer to say what everyone should have. But what I would say, there are some very clear red flags to what you shouldn't do. But yeah, if a same-sex female couple came in, we wouldn't rush to IVF. It would be donor insemination, which is essentially IUI. And it's hugely successful. 20% of people may conceive that way.
And with your kind of gynecology hat on and fertility hat on, if somebody comes in, so if somebody comes in to your clinic and they want to conceive and they've got a gynecological issue, say for example, endometriosis, what is your recommendation to that person? Should they treat the endometriosis, or is it better to go for IVF and kind of not ignore the endometriosis, but not really address it? Or does it completely depend on each individual and the extent of the endometriosis?
I mean, it does depend, of course, on individual cases. There isn't sort of a binary model that we all follow. But I think what I would say on that is, depending on the age of the patient, fertility may not be front of their mind at all. So I think let's take different scenarios here. If you took a single 21-year-old that came in with endometriosis with the most awful periods, difficulty with intercourse, maintaining relationships because of that. And then on ultrasound, you identify cysts on the ovaries. It's about improving the quality of life for that patient. But as a gynecologist who understands fertility and does a lot of fertility as my main specialty, I would always want to check that young patient's egg reserve and talk to them about the impact endometriosis has on fertility and future fertility. Now, it may be that they are blessed with a very good egg reserve, but as a surgeon as well, operating on these patients, which is the beauty of the Eve, well, we do the surgery as well, is that you would want to sort of know before you start and educate the patient about the pros and cons of surgery. But if you flick to a different situation and think about a 40-year-old with endometriosis who's been trying for 3 years to conceive, actually the data, the best research we have is that actually it's better to get on with IVF as long as those cysts on the ovaries are not too big or too obstructing to getting eggs out of the ovaries. And actually delaying and having surgery may not only reduce your ovarian reserve, but your recovery, the length of time, may also make it harder to get success with the IVF. So it's always a balance. So I don't think there's a sort of simple one rule, but there are some very key rules we follow as gynecologists and fertility specialists to make sure that you optimize not only quality of life, but also fertility.
And sort of when somebody is sort of decided IVF is the road for them, so, they're on the road, there's lots of things out there around mild IVF. And, you sort of think, you hear IVF and you think all IVF is the same. It's like, it's IVF. But obviously what we see is that there are many different types that, mild IVF, double stimulation, back-to-back, 3 egg collections, all this kind of stuff. How do you decide what is the best approach?
Again, it's there are lots of ways of doing things, and I think particularly in reproductive medicine, assisted conception, which is still a relatively young specialty. If you think it, since the birth of Louise Brown and from Steptoe's days when IVF was in its infancy to where we are now, it's less than 50 years old. And that isn't, when you compare it to some other specialties, it's advanced. It's also an area of medicine where there's definitely, because of the gender gap as well over the years with research, it's been harder to do trials and research in this area because it's hard to recruit, particularly when you're talking about fertility and pregnancy. And so there are many more unanswered questions than answered questions, actually. And we've come a long way in the last 25 years, I think, with the advancement of the specialty, but also understanding what works and doesn't work. But to kind of give a comparison, if you walk into an A&E today and have chest pain and are having a heart attack, you'll probably, whether you're in Lancashire or Thomas is in London, get the same protocol because it's well known exactly the same protocol is the best way to resolve that. And that's come through years of research and getting the best outcomes. We're not quite there yet with IVF in that sort of setting. So from my perspective, there are different patients that you see with different ages, different egg reserves. There are different drugs on the market and there are different protocols and things that you can use. Now, that comes with experience. And I suppose what the Eve World does have is a huge amount of experience in terms of the consultants that you'll see. And I would never say that we use one protocol for everyone. We absolutely don't. But we do have some favorable techniques and protocols that we will use, but you've got to look at the patient as an individual. You can't just look at them and say, well, just put them on that protocols. That's the one we do at the Eve World. That's not how we practice IVF or fertility medicine here. So it is difficult, therefore, for patients. And it also means that you've got to really do your research and find a good clinic because you may otherwise end up just being on a protocol and it may not be right for you. But I would hope not. I'd hope most patients end up in a clinic where they get good advice and somebody really looking at the detail of what needs to be done to get that patient the absolute optimal outcome.
And that's a really important point, isn't it? And I think a point that people don't necessarily realize until they're into the process. Because I think until you find yourself in the world of IVF, it is just assumed that IVF medicine is the same across the board, exactly like you said, if you were having a heart attack. But it never fails to surprise me how, each different clinic and each different consultant can have a different approach. And that for the person going through is really stressful because how do you know? Usually you kind of assume that, the consultant, the doctor tells you and you go, okay, yeah, right, that's what I'm going to do. But in fertility, it's like, there's lots of different approaches. And how do you know which one is the right one for you?
Well, absolutely right, Hannah. There's so much, there is differences. The HFEA, who is our regulator, are very good at sort of making sure that clinics do things licensed in the correct way. They also, we have an obligation as a clinic to pull our data together, and success rates are not everything, because of course there's patient experience. And when you're looking at the very best clinics, actually the success rates are very important. But there's sometimes not much to choose between, let's say, the top 10 to 15 clinics. And therefore, it's also about all those other factors that matter. So if you're coming in for a scan, what's it going to be, and can you get to your job that you starts at 9 o'clock when you're expected at your desk? Are the staff that you meet going to really be listening to you? Do you feel like a number, or do you feel part of, a really sort of a high sort of shiny service? And I think that's what we should all be striving towards, is delivering, particularly in private medicine, which often is, sadly, for a lot of patients who aren't entitled to any NHS funding, a really, really shiny, bespoke service that is absolutely tailored to that patient, giving them the best outcome. And I think it's incredibly hard as a patient, because it costs a lot of money as well. You have to take a lot of time to research your clinic. And I always say, come and have a consultation with a doctor or a clinic if you've done your research. Maybe try more than one clinic if you want to get other opinions. And I certainly have people coming to see me who are looking, and that's important. You wouldn't buy a house in 2 minutes. If you're going to invest in something as big as your future and your fertility, you want to make sure that you trust and feel that you're going to get the right results from the clinic you go to. And it does sadden me when I hear stories that like you say, because I think that's ultimately what we should be doing. It's about that attention to detail. It's about giving the highest level of care to every patient that walks in the clinic.
Absolutely. And that's kind of, when people ask me, what would you recommend? I always say, go and see a number of different places, because that's the thing. They are different. They're not all the same. And so you've got to kind of, unlike other areas of your health, you've got to do information gathering and research yourself, and, ask questions, and, just feel like you can ask the questions, and you can, go and see different options, and then you can make a more informed choice, I think. In terms of people when they're actually going through the process, in terms of preparation and supporting themselves through the process, because there has been this huge kind of awareness raising about you mentioned it before, the stress and the emotional, physical impact of IVF. What are your kind of, you see people all the time. What are your recommendations for people to, what advice do you give to people to sort of look after themselves and cope with the journey of going through IVF? What do you say?
I think it's having sat on this side of my desk a lot of the time, but also had some very close friends and even family members that have been through this, you understand that it is an incredibly brutal, all-consuming and stressful time, trying to conceive when you can't conceive, and to get this thing that you desperately, desperately want to happen, but it isn't happening. And then having to deal with that, plus all the other stuff that we just have to deal with day to day, such as, the bills coming in and having to be expected to deliver on your work objectives, and, getting the car MOT. There's all this other stuff. And then on top of it, you heap this huge problem that sometimes in relationships can be quite destructive. And I've seen it really turn people into sort of hollows of themselves in terms of who they were and their normal selves. So look, I think the biggest thing I say to people is be kind to yourselves. This is a hard process. You've got to look after yourself in terms of the emotional side. We will do our absolute best to give you the protocol that's going to give you the best outcome. And if we're not delivering on that, I want to know about it. Certainly as the medical director of the West London Clinic, if we're not achieving it, I need to know, because we don't get it right for every patient, I'm sure, but I really, really strive towards that. I think that's really important. But yeah, just be kind to yourself, because I think people are really hard on themselves, and they begin to sort of have a sort of inner search as to why this hasn't happened. And they often blame themselves, and they can actually become quite depressed with it. So that, from a mental health side of things, I think is really important, and it is all consuming. So try to maintain a modicum of normalness in your life. And if that means you have a glass of wine, that is not going to be the difference between the success and failure of an IVF cycle. But if you have 2 bottles of wine every night, that needs to be curbed. So there are sort of being sensible as well as trying to be good. there are other things. I mean, you're an acupuncturist. We also have patients that really value that. And I know there's evidence from studies that actually it can improve the outcomes. So I think there's acupuncture, there's diet, there's like the nutritionists that help patients. And I think all of these adjuncts to what we're doing in the clinic are so important. And certainly the EVOL philosophy is that we should focus really hard on really good science in the lab, making sure that the patients feel part of a clinic that really wants to look after them so that we support them, but also not be negative about these other things that people may consider, because we don't know everything in Western medicine and we don't have all the answers. And certainly, as I've said already, it's a youngish specialty and there's still 50 years ahead of us finding out stuff that we don't know. So I think we've got to be fairly open-minded. If I think a patient's doing something that isn't going to be helpful or maybe detrimental, I will of course say that, but I think it's important to support patients throughout the whole journey. And I think saying that from the beginning appointment is really important, so that you support them at the start, because there's quite a lot of excitement and dread, and it could be daunting around starting. But it's nice to be finally starting something. But we have to be honest, not every IVF cycle works. And therefore, I think it's our responsibility as well to say to patients that we don't have 100% success with every patient, but we will do our very best to get you across the line.
And sort of in a similar vein, there is a lot that, I've already done a couple of podcasts on it already, is sort of like looking more into male factor before the point of IVF. So, I think I've seen somebody this week who is having IVF, and they've had one sperm test done, and they had low motility, low numbers. And so the IVF is the answer. And so is that right? Is that always the answer? Or is because there's this whole new kind of world of, is it not better to address male factor before you get to the IVF process rather than use ICSI, which we'll talk a little bit about in a minute, to sort of bypass the male factor? Where do you stand on that? Because again, there's so much information out there and it feels like there's a lot of difference in opinion.
Well, I think you have to think back to when ICSI wasn't even a thing, and actually you didn't have ICSI. So ICSI's sort of come along, and I think that's possibly forced people a little bit more into, well, there is this thing that can overcome the fact that the sperm may not be where we want it to be. And that might well, of course, cause fertilized eggs and embryos and create pregnancies. But is it giving the absolute best outcome? I think you need to understand how severe the issues are and go back to basics. So, examining a male patient, do they have a varicocele? Do they have abnormal sort of fluid around the testes? Are the testes of a normal size? Looking at the hormone profile, thinking about the microbiome. Is there an infection that might be causing levels of damage in the sperm? Doing a really deep dive into, is there into the diet, the lifestyle, the nutritional factors that people are fueling their bodies with. Do you put lots of super processed foods into your body? Are you having a diet which consists of a lot of refined sugars? And I know that there are a lot of specialists out there that do that, but I feel quite strongly that we're the gatekeepers of trying to give people the best outcome. So I think it depends on what the level of severity of the problem is, to answer your question, I think, and also everything else. If you've got someone who's 44 and the partner has a varicocele, going away for 2 years to see if the varicocele will improve when you repair it and improve the sperm isn't an option, because by then they're 46 and your chance of a live birth is gone. So again, it has to be looked at as a whole picture. And I don't think, I think clinics certainly over the years have just pushed people through, and then they don't always get there and they don't get good outcomes. Then you go back to the beginning and then you look at the male factor side of things. And I think that needs to be addressed. And so I'm quite keen. As a man doing this specialty, I'm quite passionate we get the male factor bit right. And certainly my patients hopefully can say that of me when they come and see me. I am really interested in making sure we get that bit of it right. And I think we're the gatekeepers of good care. So we have to therefore be responsible and make sure that if there are issues there, to address it. And so there are lots of tests in our armory that we can do around that. But some men, despite doing everything and delaying, still don't have a change. And that's what I think is, again, educating patients. You need to say, look, these are the options. And then they will often, by the point they come to see us, usually just be wanting to get going. And I think, that the easiest thing is to just say, okay. But if you really strongly feel that we can make some changes, 2 or 3 months delay is not going to make a difference and may make actually the IVF outcome better.
Yeah, it's definitely something that's changing. I think people having their own understanding. People are like, they're pushing for investigations themselves. I sort of
Yeah,
feel
which
like
is,
there's been quite
I
a
think that's a
change in
good
that
thing
over
as
the last
well,
few years.
because having people looking
Yeah,
on the internet, I mean, the days of when the internet first arrived, and I think the old school consultant would have been a bit shocked to have a patient who wanted to ask a question of them. I actually quite look forward to patients that come through with sort of a pager question, because it means they've really thought about it, they've done their own research. And it also is, I don't know the answer to everything. Okay, none of us do. So I'm always learning, and patients
yeah,
ask me questions, and I'll do my best to answer all of them. But if I don't know the answer, I'll go away and find the answer. But there's a lot out there. So I think it's double-edged. I think it's good because patients can go away and do a lot of research, but it can also add to the stress, because there's a lot of information out there. And
yeah,
sometimes, I think in life people tend to like to write about things that haven't gone well. If things happen and are good, you just get on with things and you forget about it. So that's hard for patients in this domain. But there are a lot of support forums out there, and I think they are incredibly helpful as long as they're taken,
mm,
with a clinical input as well, not just in isolation. But it's
mm,
pretty normal for patients to come in now, I'd say, with a pad of questions, actually. Yeah, which I don't mind
yeah,
at all.
yeah.
Sometimes it's stronger to discuss things.
No, I think it's a good thing, isn't it? Because people need to feel sort of like they've been in control as much as
Yeah,
they can be in control in this situation, rather than, getting to the end of cycles and feel like they don't know what happened or why they're left with the outcome. So I think, the information is a really important
absolutely. And
part
I
of that.
think we work really hard, certainly from the laboratory point of view here at Evewell. Emma Whitney runs the team here, and we've got Ida here in West London, who's our lab lead. And just that if you don't get across the line, we need to know what's happened during the embryology phase, and that is so key. And I think most labs will do that, of course, but we work incredibly hard at that, and we get good results because I think it
Mm.
is that attention to detail.
So if somebody is looking to choose a clinic, so sort of, I guess, going full circle and picking up on everything that we've sort of talked about, like, how do you choose a clinic? Like, what would be you go on the internet, you do a Google search, you look at reviews, like, you look at stats, you ask your mates, you go on forums. Like, there's great, as we've just said, loads of information, but also overwhelming. So what would you say to somebody about how to choose a
I
clinic?
think looking at your personal day-to-day circumstances is important. If it's egg freezing you're doing, it's kind of quite quick, actually. You come and see a clinic and leave. But if it's egg freezing and fertility preservation, rather than actually having a baby, you need to understand how good is the clinic at egg freezing, but more importantly, how good are they when they warm my eggs up if I ever needed to use them in a few years' time? Are they giving me a baby? So those are the important questions you should be asking a clinic. And gone are the days where 60% of eggs surviving is satisfactory. A good clinic now should have upwards of 90% eggs surviving when they're warmed from egg freezing cycles, and good utilization rates of the eggs when they are warmed into embryos. In IVF, I think because not every IVF cycle works straight away, you may need to be engaged with that clinic for several months, and sometimes more than a year, and sometimes beyond that in some very difficult, complex cases. So it's got to, first of all, work for you in your day-to-day. It's no good if you live in Yorkshire and you need to come and see the Evewell for your scans. That said, we do have patients come from all over. You'd be amazed. They come to London, they stay for 3 weeks during the IVF phase, and they come and see us simply because of the results we are achieving. So it's not that would be a barrier, but on a
Mm,
general note, most people don't do that because you will tend to go where your local area is. So when you're therefore looking in your local area, you might be blessed with more than one clinic. I think cost is important for patients because it's an expensive treatment. I think knowing that you're going to get on with the team is important, and there are lots of different styles of communication, ways that clinics do things. Here at the Evewell, in both clinics, both the Harley Street Clinic, which was founded 5 years ago, and the West London Clinic, which I'm the medical director of, we have approached this with essentially trying to provide private practice all the way through. So you're not being seen by the doctor at the beginning and then you don't get seeing them at all again. You have different people all the way along the journey. With Evewell, it would be a classic example. What we're trying to deliver would be you'd see the doctor at the start. That doctor would do all of your tracking scans. they'd also do your egg collection, and they'd do your embryo transfer. And to complete the circle, if you fall pregnant and have a baby, they'd also show you the pregnancy scan, which is a really lovely thing, which is really, really hard to deliver in clinics. I've worked in clinics, and that is quite challenging. But I think it's what patients want. I think they want that continuity, and that's what we strive towards. Now, we can't have, every patient expecting that they're going to see exactly that same doctor all the way through, because of course doctors may be ill or on holiday. So, and the same with our nurses. We work with a wonderful team of nurses. We have an amazing laboratory. We all work as a huge team, and it's that team pulling together, but trying to maintain continuity throughout is I think key to success, and really, really important. So if you come and you have had embryology problems, or you're doing ICSI or genetically screening your embryos, you'll have a full consultation with the laboratory team, because that's their area of skill. Our nurses, we have nurses that scan here and help me when I've got a list that's too big. Some of my patients will see me if they have 4 scans in the cycle, they might see me for 3 of them, but have a scan with one of the nurses along the way. But the other important thing, I think, is the attention to the results that we get. So every day patients come in, they have blood tests, they have scans. We have a big meeting, which is almost 2 hours long each day, where we look at every result that's come through the clinic that day. And it's that level of care which I think really, really, really pulls up success. Now, that's not to say you need that level of care, and I don't think it's too intensive for patients or the staff, but it is about trying to get every little, eking out the best from every single person if we can. And that comes with really scrutinizing things and having a system of continuity. I think it's harder if you see a different person. You're having to re-explain yourself each time it's a new doctor or a different nurse each time for patients having scans and tests. It is important. So I think continuity is really, really, really key. How would you know that? I think ask the questions when you go for your consultation. Sit down. How do you run your how do you run your clinic? Who am I going to be seeing? Ultimately, as a patient, you're the one spending the money, so I would be the person asking the question. You wouldn't go on holiday without exploring exactly where you'll be staying and what it's going to be. So you shouldn't do that with fertility treatments either. So work really hard, look at the clinics. Of course, costs is important, but some of the more expensive clinics actually are some of the ones that provide a slightly more bespoke kind of driven service. And that's the other thing to understand when you're looking at costs. And of course, success rates. I mean, the HFEA data is there. I co-founded a website that shows how costs can vary between clinics, called Total Fertility, where patients can look. So there are lots of ways out there to kind of look at data in your area, but ultimately it's all out there in the public domain. It's just you've got to do the work as a patient to find it. But don't be afraid to ask questions. Would be my top tip, really.
Thank you, Ed. That is super, super helpful. So I will put all the details of the clinic, obviously, on the show notes. And I just want to say thank you so much for taking your time out of today to come and speak to us, because that's really, really helpful.
Thank you so much for the time today. Great host.
If you've enjoyed listening to this and want to find out more, then come and join my free community in Facebook. We have loads of resources. You can catch up on all our previous webinars and be the first to know about forthcoming events. To sign up, just follow the link in the show notes. And if you'd like to work one-to-one with myself or one of the team, then please see our website, hannahpern.com, where you can book in directly or organise a discovery call to find out how we can support your fertility and your reproductive health.